Dr. Scavella, I represent Hawaii, 2,500 miles from the continental United States. And although the city of Honolulu has solid centralized VA and TRICARE capacity, still it presents problems that we're 2,500 miles from the continental United States. And that's before we start talking about the other islands of Hawaii, which are separated not by roads and trains and buses, but by ocean. So the only way to get there is by air. And indirectly, I represent really the larger Indo-Pacific, so places with significant veterans populations like the Philippines, like Guam, the CNMI, Palau, the compact countries, American Samoa, where we have significant veteran populations. Philippines, I think it's 30,000 if I'm not mistaken, and even a small country like Palau with a total population of 20,000 has significant numbers of veterans. American Samoa, reportedly, and I think this is accurate, has the largest pro rata population of veterans in our entire system. And so I've been very interested in how do we use whatever tools are at our disposal, modern technology, innovative ways of thinking, to push healthcare out there, to give flexibility out there. For example, going back to the Philippines, where I just was the week before last, St. Jude's, which is one of the best private hospitals in the Philippines, in Manila, is used on a TRICARE basis by our veterans, apparently pretty successfully, to the point that veterans from other parts of the Pacific go there for their own care, as opposed to, in some cases, flying to Honolulu, which is fine. Wherever they can get the care is great. But all of which is to ask you, in the president's budget and in your own thinking, where are the next chapters of getting health care to parts of this country that do not live in cities, do not live in the centers of your administrative, districts? Telehealth, we've talked about repeatedly, CBOX, et cetera, et cetera. What's the big picture on that, and where should we be going now?
So thank you for that question. I think we have to think innovatively, as you've just described. We have programs in place to deliver tablets so that we can provide different types of video assistive care to veterans. So telehealth is definitely a modality that we would like to leverage, and we know that there are ways to potentially use that to surround even care that requires procedures in a facility. So I think we have to leverage that and think about that. We partner with our Office of Rural Health to look at different solutions related to that. And I think the most important thing is for us to continue to have conversations so that we understand the needs of the population that you represent, as well as those other areas that you just described, to ensure that we are meeting those needs. Those are very challenging areas, and we definitely understand that. So we will continue to partner with you.
I mean, what are the frontiers of telehealth? Are we approaching the edges of the frontiers? Is there still room to grow there? What are the next chapters of telehealth to solve this issue?
So I think there is still room to grow there. We know that it's limited by the connectivity, essentially. So we would really need to understand if there are barriers to telehealth because there's not broadband. So those would be things we would need to look into. And I know that there were some provisions in some of the American Rescue Plan related to that. And so I know that we would need to take a look at that to see where the shortcomings may still be. But I do believe there are probably lots of capabilities, but we just need to continue to think outside of the box to make sure we're providing the care that veterans in those areas need and deserve.
And then just in terms of primary care in these communities, more remote communities, I mean, are we still kind of expanding the scope of practitioners that can actually provide, effective services to, VA participants in those communities, as opposed to kind of you have to have an MD after your name to provide the services model?
So there are lots of different types of healthcare practitioners that can serve in this particular space that you're describing of primary care. So we are looking at that as well. We do have providers that are not physicians providing primary care, and that is definitely something we will continue to do. There is a shortage in this country, as you're aware, of healthcare providers. So really going into spaces to encourage people to go into this particular area to make sure that we are recruiting that pipeline early on to ensure that we have people providing all types of services that wrap around that support veterans and the American public. So I would say that we would need to do many different things, but physician-specific care for certain things is not necessarily required, nor is it what we practice within VA. We do have multiple different types of licensed independent providers who are providing care, especially in the space of primary care.
Okay, well, thank you so much. I think the VA has done a good job of trying to think innovatively about pushing care out rather than requiring people to come to the care. And that's going to be necessary to reach many, many of these populations. So thank you very much. I think I'm turning this back to my chair.